Namaskar. Welcome to this training session on maternal nutrition. I'm Dr. Shebonti Ghosh, your trainer, and I'll be taking you through the session today. So today we would be talking about evidence-based maternal nutrition. To start with, we would like to discuss about the importance of maternal nutrition. We will be talking about the impact of maternal undernutrition on women's health and well-being, on pregnancy and birth outcomes, and on newborn and infant outcomes, health and development. We will also at the same time be looking at the current status of maternal nutrition in the country, and we will also go through the globally and nationally recommended maternal nutrition interventions which are needed for a positive pregnancy outcome. These recommendations are through World Health Organization and Ministry of Health and Family Welfare. So let us now understand why maternal nutrition is so critical. Maternal nutrition is the foundation stone for child's growth and development. Do you know that 70% of the brain develops in utero only? Poor maternal nutrition is responsible for fetal growth restriction. How do we define fetal growth restriction? It would be evident when you have a term baby but smaller than gestational age. And this fetal growth restriction is behind stunting globally, one of the lead causes for stunting globally. So we have evidence showing that out of the 44 million cases of stunting in the world, almost 11 million is due to fetal growth restriction. So here lies the importance of maternal nutrition. Now let us look more deeply how maternal undernutrition is affecting maternal health and nutrition, infant and young child health and nutrition status, and also the intergenerational impact. Poor dietary intake prior to conception and during conception leads to maternal undernutrition, poor gestational weight gain. This is important because we face a high burden of low birth weight in the country, and the main predictors for low birth weight include poor maternal nutrition status, inadequate gestational weight gain, and short maternal stature. What are the negative impacts of maternal undernutrition on maternal outcomes? We are likely to face higher number of abortions, stillbirths, preterm labor and birth. There will be delayed postpartum recovery. There is enhanced risk of mortality from postpartum hemorrhage, higher chances of morbidity and mortality from preeclampsia, eclampsia, and subsequently impaired reproductive and productive capacity of the women. Undernourished and or stunted mothers, they are likely to be giving birth to preterm babies, low birth weight, or small for gestational age babies. So maternal undernutrition further results in physical growth impairment. There is lowered immunity, increased risk of morbidity, poor cognitive development and learning achievements later in the school-going age, and ultimately reduce productivity in adult life. Also, please remember that fetal growth restriction, which we were discussing earlier, while it is a lead cause for stunting, this also contributes to newborn mortality, because when you have maternal undernutrition, the newborn has enhanced risk of morbidity and mortality. Intergenerational impact is very clear. The stunted growth in girls leads to short stature, impaired cognition, and poor nutritional status in adult life. So it starts with the birth of a girl child who is small for gestational age or low birth weight and is stunted during childhood and adolescent years, and then she becomes a small adult woman, that is underweight, stunted, and likely to give birth again to a low birth weight infant. Annually, 6 million small for gestational age births result or are associated with maternal short stature. We must also understand the risk of adolescent pregnancy that also impacts the girl child and further leads to higher risk of low birth weight. And in South Asia, including India, do you know why we have such a high prevalence of low birth weight in South Asia, particularly in India? The reason is maternal undernutrition, poor nutrition prior to conception and during pregnancy. That results in such a high prevalence. We lose every year 8 million infants due to low birth weight. In continuation with our discussions on importance of first 1,000 days and maternal, infant and young child nutrition interventions, we all realize that it is very important that we prevent fetal growth restriction or fetal stunting. So why do we need to prevent? The first reason is that fetal growth restriction, which we have just now also touched upon, it is one of the lead causes for stunting. It is also responsible for more than 500,000 newborn deaths globally. Then the next important point is that beyond a certain age, after 2 years, it is very difficult to reverse the impact of stunting. Whatever actions we take, they are late, delayed actions, costs you more, and we really do not have much evidence to say how those actions will work for improvement. And thus, if we want to prevent fetal stunting, we have to really understand the timing of fetal stunting. That helps us to intervene at the right time. Studies have shown that fetal stunting is evident by 8 weeks of gestation. So, fetal stunting is resulting due to insults which are happening in pre-pregnancy state or very early in pregnancy, that is in first trimester. Fetal weight velocity peaks at 30 weeks of gestation. Wasted intrauterine growth retardation arises from growth retardation during third trimester of pregnancy. Peak fetal length velocity occurs at 5 months of gestation. So what is this telling us? So we are realizing that the origin of IUGR is prior to birth, and we really need to act early so that we can stop the insults which are happening as early as first trimester of pregnancy. Now let us understand the current status of maternal nutrition in India. We do have a favorable policy and program landscape. However, the status is suboptimal both for maternal and child nutrition. So as we start looking at the statistics for maternal nutrition in the country, first of all, let us recognize that we now have the maternal mortality ratio going down to 113 per 1 lakh live births in 2016-2018 compared to 130 in 2014-2016. But we have 22.9% of women in India who are entering pregnancy underweight. That is, they have a body mass index which is below 18.5. We have over 50% pregnant women anemic in the country, but only 30% consumed IFA tablet for 100 or more days. But at the same time, please remember that pregnant women, over 80%, almost nearing 90%, had received the tetanus toxoid injection from the system. The average weight gain in pregnancy is only 7 kg. We have a high burden of low birth weight, with 1 in 5 babies being born low birth weight. We still have 20% of women who are not delivering in institutions. To further add to the problem, we have quite a considerable proportion of women who are marrying before 18 years, which stands at 26.8%. Adolescent pregnancy rate is 8%. If we look at girls in the age group of 15 to 19 years, 42% are underweight, and over half of them, that is 54%, are anemic. Amidst all this, we now also are facing the growing burden of overweight, obesity in women. So we now have 21% of women in the reproductive age group who are overweight or obese. Now that we are aware of the importance of maternal nutrition and its impact, we have also looked at how severe the problem is in the country. Let us now understand the evidence-based maternal nutrition interventions which are recommended by WHO and Government of India. So let us now look at all the recommended maternal nutrition interventions. The first one is on counseling. Counseling on healthy eating, that is, eating adequate and diverse diet along with physical activity. The second recommendation is, in undernourished population, nutrition education is important to improve the energy and protein intake so that we can reduce the risk of low birth weight. Third, in undernourished population, balanced energy and protein dietary supplements are recommended to reduce the risk of stillbirth and small for gestational age. Fourth, very important, daily iron and folic acid supplements. The composition is 60 mg elemental iron and 500 microgram of folic acid in each IFA tablet. This is recommended to prevent maternal anemia, sepsis, low birth weight and preterm birth. The supplements need to be taken from second trimester of pregnancy for 180 days and again for 180 days postpartum. We have already touched upon this in the first session as well. Next, calcium supplementation. 500 mg calcium tablet twice a day is recommended to reduce risk of preeclampsia, eclampsia and preterm birth. Calcium supplementation is also recommended from second trimester onwards for 180 days and again 180 days postpartum. WHO recommends vitamin A supplementation only when vitamin A deficiency is a severe public health problem in the country. Seventh, iodized salt consumption is recommended to prevent abortion and stillbirth and improve neonatal outcome. Iodine in adequate amount prevents brain damage, congenital defects, speech and hearing impairment, intellectual disability and mental retardation in the child. 8. Deworming is recommended. Single dose of 400 mg albendazole tablet during second trimester of pregnancy. WHO currently does not recommend high protein supplements, vitamin B6, vitamin C, vitamin D and vitamin E supplements. Very recently, WHO has recommended that multiple micronutrient supplements, which also include iron and folic acid, can be given only in the context of rigorous research. We must remember that pregnancy is a very demanding physiological state and all the nutrient requirements go up. And this additional nutrient requirement is for healthy development of the fetus as well as to support the growth of maternal tissues which support the fetal development. Now let us look at what the additional requirements are. As per the revised guidelines from ICMR, during second and third trimester of pregnancy, the pregnant woman requires an additional 350 kilocalories per day. The protein requirement also goes up. It is 9 gram per day additional protein requirement in second trimester. It peaks during third trimester at 22 gram additional protein requirement per day. Now we can also look at the visual and understand the additional requirements of micronutrients and vitamins including iron, calcium, folate and vitamin A. To meet these additional requirements during pregnancy, a pregnant woman needs to be counseled about healthy eating. This includes eating diverse and adequate diet during pregnancy, along with regular consumption of IFA and calcium supplements. Pregnant women in first trimester should be counseled to eat at least 3 full meals a day. During second and third trimester, she should be counseled to eat 3 full meals along with 2 nutritious snacks a day. We need to counsel pregnant women how they are going to consume IFA and calcium supplements regularly. At the same time, we need to also explain and reassure them about some of the side effects which are minor associated with IFA consumption. So IFA tablet needs to be taken once daily, preferably at bedtime and with lemon water. Calcium tablet needs to be taken after the morning meal and again it needs to be taken after the evening or the night meal. Please remember, we should not be taking calcium tablet empty stomach. Also, the pregnant woman must be advised that calcium and IFA tablets should not be taken together because that would adversely affect the absorption of iron. IFA tablets also should not be taken with tea, coffee or milk. As I mentioned that there are some minor side effects like nausea, vomiting, constipation associated with IFA tablet consumption. Pregnant women must be explained and reassured that these are not serious side effects. They will subside within a few days. For example, to avoid constipation, she should be encouraged to drink plenty of water and fluids and also include fiber-rich food items in her diet. Pregnant women should be also encouraged to eat vitamin C rich fresh fruits so that the iron absorption is improved. During antenatal checkup, we need to measure the weight of the woman at every contact and also calculate the weight gain. ICMR recommends that on average the weight gain during pregnancy should be between 10 to 12 kg, which means from second trimester every month there should be a weight gain of 1.5 to 2 kg. We need to be alert that the weight gain is not below 1 kg in a month or above 3 kg in 1 month. In such scenarios, we have to refer and manage the pregnant woman as a high-risk condition. Nowadays, the evidence also says that it is best to calculate the weight gain according to the pre-pregnancy BMI of the woman or the BMI which is calculated within the first 20 weeks of pregnancy. You can see that in the visual. I hope you liked this session, understood it and found it useful, and you would be able to also implement this in your everyday practice. We will do a quick recap before we close the session. Maternal nutrition interventions during ANC helps prevent the risk of preeclampsia, eclampsia, anemia and micronutrient deficiency, and also maternal mortality. Same time, undernourished mother and stunted mother likely to give birth to low birth weight baby, small for gestational age baby, and have preterm birth. So maternal nutrition interventions help prevent SGA and LBW. Fetal growth restriction is one of the leading causes of stunting worldwide. During pregnancy, please remember pregnant women has higher requirements of energy, protein, various micronutrients and vitamins. ICMR recommends additional requirement of 350 kilocalories per day during second and third trimester of pregnancy. Please remember to counsel pregnant women on the importance of consuming an adequate and diverse diet along with regular intake of IFA and calcium supplements. IFA and calcium supplements start from second trimester. It is important that you regularly check and track the weight gain of pregnant women during ANC visits. From second trimester onwards, the recommended weight gain per month is between 1.5 to 2 kg. So I conclude the session now, and I hope it's of use to you and you have understood it.